Good morning, everyone. Today we will see how we approach a newly diagnosed multiple myeloma patient, and we will cover first. We'll look at the diagnosis, how it is done, and what are the finer points we need to pay attention to. Then next would be risk stratification. Then we will also look at response assessment. That is something we routinely do. So we'll see some points there, and then we move on to treatment of transplant eligible and non-eligible multiple myeloma, and finally we'll have some concluding remarks. First of all, uh, very common thing which happened to us is a referral for M-band or a monoclonal gammopathy. And it is important to remember that in a community setting or setting outside hospital, most of the times or the most common cause of having M-band is not multiple myeloma. And all these disorders together are called as monoclonal gammopathy. So what they are common is a presence of a M-band, and in some of them monoclonal plasma cell, but at some places you will have some lymphomas producing M-band or some other disorders causing monoclonal M-band. So M-band doesn't mean multiple myeloma, and that is important. Whenever you have M-band, obviously we'll look at whether the person has multiple myeloma, but other disorder like amyloid, lymphoproliferative disorders, and other common thing needs to be ruled out. Then move on to diagnosis of multiple myeloma. Diagnosis of multiple myeloma in a florid case looks very simple and straightforward, and most of the time we don't really have to go down these criteria. But it is important to understand these criteria have been laid with some purpose, that patients are classified uniformly, and that is not only for clinical trial purposes but also for our patient day-to-day management. This is International Myeloma Working Group diagnostic criteria, which have been modified last in 2014. And what they require is the presence of a, you can say that's a mandatory criteria. So you should have a monoclonal plasma cell more than 10% in the bone marrow, or outside bone marrow, you should have evidence of monoclonal plasma cell in the form of, for example, plasmacytoma. And that is absolutely essential. Without that, you would not be able to diagnose someone with a multiple myeloma. The next comes is the presence of myeloma defining event. We call them MDE. It is also important to note that this MDE has to be attributable to underlying plasma cell disorder. Unrelated cause for this would not constitute a multiple myeloma. And these are CRAB, which we are very familiar with, but this time they have led us correct or stricter guidelines. So calcium more than 1 milligram above your normal range for your lab, or more than 11 gram. Then GFR less than 40 or creatinine value more than 2 milligram per deciliter. Then hemoglobin less than 2 gram for your lab, less than that, or less than 10 gram per deciliter, and presence of a lytic lesion which can be seen on the X-ray, CT scan, or PET scan. So even a single lesion will qualify for presence of multiple myeloma. So these were the older myeloma defining event, but what they have done this time is they have added some biomarker based definition, and these are conditions where the person doesn't have multiple myeloma related damage right now, but his chances of having multiple myeloma with these CRAB features in the next 10 years was more than 80%, and they thought this risk is too high to wait, and we don't want person to have end organ damage because of myeloma. So these are called as SLIM. So S for 60, so bone marrow plasma cell more than 60%, involved to uninvolved light chain ratio more than 100, so that is LI, light chain, and MRI showing a more than one focal lesion. So this is not a lytic lesion on the bone. This is a marrow lesion, and it should be 5 millimeter in diameter, and 2 lesions should be there. So now we are familiar with CRAB, but it is important to remember this SLIM plus CRAB. So this is a diagnosis of multiple myeloma, and this should be kind of looked into whenever you don't have a clear or florid diagnosis of multiple myeloma. And there are other definitions in the same classification. So these are precursor conditions where these people have a risk of development of multiple myeloma in the next few years. So this is commonly a monoclonal gammopathy of undetermined significance, and that is divided into IgM and non-IgM MGUS. And there is also a rare entity called as light chain MGUS. So basically here you just have an M-band. You don't have a plasma cell more than 10%, so they are less than that. You don't have any of these myeloma defining event, and then you see the risk here. with non-IgM MGS, it is 1% per year. So very low risk of progression to multiple myeloma, and there are risk stratifications to predict that. So this we should be aware that person may have a monoclonal gammopathy, which is a precursor condition, and most of the multiple myeloma, they would progress from initial precursor stage like this. So this can be divided into two parts. The precursor condition first is MGVS, so where you require M-band to be less than 3 gram per deciliter, urine BJ protein less than 500, and you should have less than 10% plasma cell, and obviously none of those myeloma defining event. And you have a smoldering multiple myeloma, so it is in between MGUS and multiple myeloma, where your M protein is more than 3, or you have BJ protein more than 500 milligram per 24 hour, and bone marrow plasma cell between 10 to 59%, and obviously there is no myeloma defining. So this becomes a smoldering multiple myeloma, and obviously plasma cell percentage more than 60 is one of the slim criteria. More than 60% will become active multiple myeloma as per the current definition. And this is important because the risk of progression, as I told earlier, is different. So for MGUS, it is roughly 1% per year, and risk is quite constant throughout the remaining lifespan of this patient. Okay, but this condition is much more common. So roughly 10% of the people above 60 or 70 would have MGVS. So it is a common condition in the community setting. But for smoldering myeloma, the risk is not that uniform. So the risk is really high within first 5 or say let's say 10 years. So it is roughly 10% per year within the first 5 years. After that, it starts plateau down. So after a decade, it comes down. But it is important to realize the difference between two, so that appropriate monitoring strategy or your for that matter therapeutic approach for smoldering multiple myeloma can be different. Moving on, we also should be aware about how we diagnose plasmacytoma. So solitary plasmacytoma should have only one plasmacytoma. There should be no other myeloma defining events, and bone marrow should have no clonal plasma cells. So this is absolute diagnosis of solitary plasmacytoma. But you could have a plasmacytoma with minimal bone marrow plasmacytosis, where the bone marrow plasma cells are less than 10%. So the difference between two here is the risk of progression of solitary plasmacytoma with minimal plasmacytosis is higher as compared to solitary plasmacytoma, and that is one thing we should note when we treat this kind of patient. So finally, when we have a monoclonal gammopathy or an M-band in a person, and if there are clinical signs and symptoms, then the diagnosis is very straightforward. If you have a common multiple myeloma manifestation, slim crab, you have a diagnosis of multiple myeloma. You could have amyloid and Waldenström macroglobulinemia as a diagnosis in appropriate clinical context. There are uncommon gammopathy associated disorder like Poem syndrome, MGRS, and other rare entities, and we should be aware about that. When you don't have any of this, then you go on this precursor condition route, and this could be like MGVS or a smoldering multiple myeloma, as we saw earlier. And this is important because many times you will get a referral for mildly raised creatinine, which could be just because of diabetic nephropathy, and a small M-band is found. So we should be aware about this diagnostic criteria, and it is important not to call them multiple myeloma in a hurry. We'll speak about electrophoresis immunofixation a bit. This is commonly done to screen and diagnose multiple myeloma. So electrophoresis is a simple protein electrophoresis, gel electrophoresis, which is done on a like any other electrophoresis, and you will see a M-band. So this component here is a monoclonal component, and this can be quantified. So you get a M-band concentration. What you see on the right side is immunofixation, where what they do is they put antibodies against this different antibodies. So these are antibodies against antibodies, and in this immunofixation you see a positive staining for G, so that is IgG, and you see kappa. So electrophoresis and immunofixation are two different things. Electrophoresis is less sensitive, immunofixation is more sensitive. Immunofixation is able to type the M-band, what kind of M-band a person has, while electrophoresis will show you M-band and you can quantify that M-band. So we should be aware about, because you don't have to do electrophoresis or immunofixation in every case, especially at the follow-up, as we will see later. The next commonly confused concept by some of the people is serum-free light chain assay. So you don't have intact heavy chain and light chain, both the intact immunoglobulin molecules. Sometimes we have only light chain being produced by multiple myeloma. So these are the light chain which are bound to the immunoglobulin molecule. So this would be, if you measure this will be reported as a total kappa light chain and lambda light chain. But when you have them as free, when they are unbound, then you call them free light chain assay, and that is what we are measuring, or what is where we are tracking in multiple myeloma cases. And how they are detected? They are detected by using antibody against those hidden epitopes. So this is something which we need to understand, and not to confuse total light chain with serum free light chain. And they are useful in certain cases where intact immunoglobulin is not produced, and we should be aware about this difference. New modality which is coming to detect multiple myeloma is mass spectrometry. So what what this does is compare. This is basically a protein detection method. It compares the mass to charge ratio of an individual protein, and that is how it will track the protein. So this is very sensitive. Second thing is this is very rapid, and turnaround time is simple, and this also works cheaper. It is not very laborious like doing electrophoresis immunofixation. So this is being utilized in the center wherever the expertise is available, and we are likely to see it more in multiple myeloma field, and also its application in MRD detection in multiple myeloma. So finally, when we are faced with a multiple myeloma suspected patient, we have to do is electrophoresis and immunofixation. Once we have done this, we also have to do a protein electrophoresis, because you may have majority of M component being secreted in the urine, and it is mandatory. Sometimes we forget about this. Next thing is to look at the serum free light chain assay, and we may use to track these patients. So we will see what to track in the next slide. We also have to do bone marrow aspiration biopsy. We also have to look at the cytogenetics for risk stratification in these cases. And sometimes you may have to do plasmacytoma biopsy if there is nothing in the bone marrow, but rare to rare cases. And there are other set of tests which are required to define the myeloma related end organ damage. And we look at CBC, creatinine, calcium. Then we look at LDH and beta 2 microglobulin as a burden of the disease. And bone imaging. So nowadays we don't do skeletal surveys or routine X-rays because of the sensitivity issue. And recommended imaging modality is either a low dose whole body CT or PET CT or whole body MRI, and which is quite convenient, and they have some advantages in terms of response assessment as well. And sometimes you have to do additional workup, like if you're suspecting amyloid, then you want to look at whether person has a nephrotic syndrome, person has a cardiac involvement, etc., depending upon case to case basis. So this is basically a workup of newly diagnosed multiple myeloma. One thing which I want to point out is the association of multiple myeloma and amyloidosis. So roughly 10% of the patient with multiple myeloma will have amyloid, and it may not be as florid as seen in this case. So this lady had a skin amyloid, she had a neuropathy and carpal tunnel syndrome, and she also had a macroglossia and a soft tissue deposit. So it is important to look for this. So you should look for any excessive edema, macroglossia, peripheral neuropathy, or any history suggestive of cardiac involvement, because this is 1 in 10. So this is not that uncommon. And second thing is it will have management implications. Usually the tolerance to treatment of this patient are very not very good. So we should be aware about this. We'll move on to prognostication. So traditionally, a staging system which is popular was ISS, and this has been revised in 2014-15, and that is now what we use is revised ISS system. So basically, it has two components: the original ISS system, which is a measure of the disease tumor burden, and this is not a really biological one. So beta 2 microglobulin shows the disease burden, and it has issues in person with renal failure where beta 2 microglobulin will be raised. So ISS3 could be because of high disease burden, or it could be because of renal failure. And next thing is it takes into account albumin, which is kind of taken as a surrogate marker for disease related inflammation and other things. The other component which is used in this staging system is cytogenetics. So basically cytogenetics is multiple myeloma. It is myeloma is classified as hyperdiploid myeloma and non-hyperdiploid myeloma, and other myeloma, which is, these are basically different forms of myeloma which are right from the beginning. So either it will be hyperdiploid or non-hyperdiploid, and it will be having IGS translocation or not. So these are the things which don't change with time. So what our ISS does is it uses ISS staging, LDH, and cytogenetics to classify patient into RISS 1, 2, and 3. So a person with ISS 1, normal LDH, and no high-risk cytogenetic, which is deletion 17, 414, and 1416 in this system, is called as RISS 1. If you are ISS 3 and if you are either raised LDH or high-risk cytogenetic abnormality, you are called as RISS 3, and everything remainder is RISS 2. So this system is prognostic. So for example, in the original paper, you could see that the outcome of these patients are 2.5, 3.5, and roughly 5.5 years median progression-free survival. So this can be used for counseling and planning patient treatment. But this is too broad, and this is probably leaves many other prognostic markers outside, and that is why there are refinement in this. So deletion 17p, this is I think most important prognostic marker because it has the highest impact on the prognosis, and that's a bad impact. There is some discussion about the frequency of 17p deleted plasma cells. So more than 55% as shown in this IFM study was relevant, while if it was less than 55%, then the median PFS was more than 6 years. So they say this cutoff can be used. And there is discussion about P53 mutation in addition to deletion. So you will require a P53 sequencing, but that is supposed to be bad. So you would have a complete loss of P53 function in such cases. And P53 can be acquired. So this is not like a IGS translocation or a hyperdiploid cases. So it might be relevant to look at this in person as relapse. And there is some data that bortezomib helps this patient to improve outcome. And that is usually recommended as a part of treatment of this patient. We move on to next part, common cytogenetic abnormality, that's IGS translocation. So common are 4, 14, 11, 14, 14, 16, and 14, 20. And out of this, 4, 14, and 14, 16 have been included in the revised ISS. 4, 14 is quite common, but its reported studies have shown a varying result. So it is heterogeneous. Some people say that it depends upon the breakpoint where what is the breakpoint on chromosome 4, and other associated like your ISST, your hemoglobin associated. So it is having variable prognostic impact. 1416 is rare abnormality. It is less than 5% of the patient, and it is associated with many bad abnormalities like deletion 17, deletion 1p. So whether it is independently prognostic, it is not known, but this is the part of current ISS. Another cytogenetic abnormality to note is 1114. So this doesn't have a bad prognostic impact, but this leads to BCL2 overexpression, and this can be targeted by venetoclax. So this is important to keep in mind. Then some abnormalities can be acquired. So chromosome 1 abnormalities like deletion 1p, which is less common, less than 10% of the people over their disease course will show it positive, but it has a very bad prognostic impact. So once we acquire the PFS of this patient were less than 2 or 2.5 years. So this is rare, but really a bad prognostic abnormality. 1Q gain is again subdivided into amplification or non-amplification depending upon the copies of 1Q. And this is quite common. So roughly 35% of the people would have this kind of abnormality, and it has a prognostic impact. So now what we see is we are getting more and more abnormalities. Some are baseline, some are acquired during the treatment or during the evolution of disease. So there are attempts made to use all of them, and this is a prognostic model developed by IFM where they have come up with a risk score, and the heaviest weightage is given to deletion 17p followed by deletion 1p, and trisomy 5 is good prognostic marker. Trisomy 21, surprisingly, we think hyperdiploid are better, but this is also poor risk abnormality, and they have come up with a score. So this has been validated in validated, but we probably would have more data coming on this. And these are the outcome of survival in the training and validation cohort, and it shows kind of probably nice separation, and also classifies patient into 3 even subgroups of weightage. The next important prognostic marker is MRD, so which has come up recently. So a lot of studies, meta-analysis have shown its impact, and the impact is not only on progression-free survival but overall survival. So this is a IFM 2009 data where you could see that if someone is MRD negative, has better outcome, and that is why it has become a new goal of your treatment. So you should be able to achieve MRD negative with your treatment. And probably one thing which is now accepted is if you achieve MRD negativity, it is important rather than how you achieve it. So though more active treatment will lead to higher percentage of MRD negativity, but MRD negativity is a important prognostic marker, and it should be a goal. So where in this IFM study, MRD negative patient, whether they were in transplant or non-transplant arm, they did better as compared to patient who were on MRD positive, even if they received transplant. So this is new prognostic marker. We move on to response assessment. This is what we do it, day in and day out, and I suggest that you go through this consensus paper of IMWG carefully so that we classify them. Important thing is to note that not every M band is measurable. So measurable M band is defined when M protein is more than 1 gram per deciliter. Urine BJ protein should be at least 200, and light chain assay, the involved light chain should be more than 10 milligram per deciliter, and ratio should be abnormal. Otherwise, this is not measurable by M protein, and you will have to look at bone marrow plasma cells or maybe imaging modalities. Another recommendation which this IMWG paper has given is serum free light chain assay should not be used for response assessment when you have measurable M protein or urine M protein, and that is something which we should also practice in our clinical practice. They also have given guideline what to do when we have a response. So for example, electrophoresis is required for every response assessment. Immunofixation is required only when you are suspecting that person has achieved a CR and your electrophoresis is not positive. And urine BJ protein also required for every assessment. Serum free light chain assay, as per this recommendation, only when you want to qualify someone as a stringent CR, then it is required. Bone marrow aspirate and imaging are required when you want to qualify for a CR for this response assessment purpose. Otherwise, they are not required. So basically, you have to individualize a response assessment method for individual patient. This is best decided at the baseline, and depending upon the electrophoresis value, you could ask for additional testing so as to qualify for this. Then these are the criteria which are useful for not only for clinical trial but for our routine day-to-day assessment, because even previously when we don't have MRD, our goal was to have at least VGPR or better response assessment, as it correlated with better outcome. And this has different cutoffs for M band, different cutoff for urine BJ protein, and many times people confuse, like for example, if as per this guideline, if someone has a serum free light chain assay as the only measurable M component, then that person can never be put into very good person response category. Okay, it is quite obvious. So despite this, we kind of do it in hurry and misclassify many patients. So go through it. Important thing is that M component and serum free light chain assay reduction would complete absence would lead to a complete response, and this has to be qualified by presence of less than 5% plasma cell in the bone marrow, and up to 90% reduction in the M band, and urine BJP less than 200 is VGPR, up to 50% reduction in the M protein, and urine BJP less than 200 milligram is partial response. If your urine BJP is more than that, then many people will go into minimal response category. And these are the progression criteria which are different from the having a clinical relapse. So this will be useful to look at the progression-free interval in your patients, and you should go through them carefully so as to note the progression-free interval, not only for clinical trial but for documenting prognosis in your patient. Then clinical relapse is one which we treat, which we consider indication for retreatment, and where this is also quite objective as compared to the previous. So if you have presence of hypercalcemia, hemoglobin drop less than 2, creatinine rise more than 2 milligram per deciliter, and obviously all these things has to be attributed to the relapse of multiple myeloma. So this will help you when there are small changes in the value and day-to-day decision making. Then they also recommend doing MRD assessments. So it could be imaging negative MRD or a bone marrow flow based MRD. So that is flow MRD negativity, and there are Euroflow guidelines for same. And you could also do a MRD by a next generation sequence, the clonoSEQ assay. So we'll move on to treatment part, and I think important is to note that the importance of first line treatment. So many patients do not receive second line treatment. So this is a very, I think, revealing paper from Australia. I think their healthcare system is really good. So people who are less than 70 years of their age, only 60% patient receive a second line treatment. If they are more than 70, only 35%. So your patient may not be able to receive second line of treatment, and that is why it is important to plan a first line treatment very good. Second thing is we should also make an attempt that no, we don't lose the opportunity to treat this patient, and they have to receive subsequent line of therapy for optimal outcome. So this is with this backdrop, we will see the treatment of newly diagnosed multiple myeloma. So it is divided into different phases. First phase is induction, where disease burden is very high. You want to decrease the disease burden quickly, avoid or cease the end organ damage which is ongoing because of this disease burden, avoid early issues like mortality because of infection and other risks. Second thing is consolidation, where the person's performance status is improved, his general condition is better, and you want to give them more treatment so that the disease burden is further decreased. And last phase is maintenance treatment, where disease burden is very low. You could give them reduced intensity treatment, sometime immunomodulatory treatment, which will work on for long. And these are the different phases. So sort of the boundary between these sometimes blurs because we use chemotherapy only, but it is important to note that every step is different. They have come from different clinical trials and they have different function as well. So historically, the treatment was chemotherapy based, so VAD or melphalan prednisolone. Then transplant was important treatment part because you hardly have anything before transplant or anything after transplant. And in those days, tandem transplant was also considered. So second consolidation transplant was also done. Maintenance, there were data with interferon mainly, but not. So the treatment has changed a lot in this. And induction treatment, so we divide this patient into transplant eligible and ineligible depending upon their organ function. Not strictly going by their age, but it is difficult to do transplant for a person more than 65, 70 years in our setup, and that has to be evaluated. So goal is to control the disease fast so that you cease the ongoing organ damage. You have to get a good depth of response, and your aim is to get the MRD negativity. You have to avoid toxicity because this is a time where a person is likely to have maximum therapy related complications. Traditionally, the induction mortality should be less than 1%. So that's something which we should keep in mind. And for transplant eligible patient, you should be able to preserve the stem cell. So you have to avoid stem cell damaging agent. Coming to options for transplant eligible, so there are plethora of options. There are many options in as per the NCCN guideline, and they come from different trials. So we are actually having a lot of treatment options nowadays, and broadly they could be divided into two groups. So there is no doublet here. There is always a triplet. So that's the history that triplet do better than doublet, and novel agent based induction do better than non-novel agent based induction. So VRD is the category 1 recommendation for NCCN, and we will discuss that further. The next is alternative second generation proteasome inhibitors. So carfilzomib based regimens are here. And next is monoclonal antibody based quadruplets are also there as an option. So we'll see data for some of these regimens. So first, let's see one study of VCD, which was quite commonly used and popular regimen in India and many countries, because we wanted to keep some drug for salvage. And this study clearly showed it is a VCD versus VTD IFM randomized controlled trial in a transplant eligible patient. But when you use VTD, you increase the VGPR or better responses by roughly 10% in this patient population. And you know that pre-transplant VGPR translate into post-transplant outcome as well. So definitely VCD is an inferior regimen and should not be used or practiced even in our setup now. There is toxicity difference. So for example, VTD is having mainly toxicity is neuropathy, while VCD is myelosuppression because of the cyclophosphamide. So that you should keep in mind. Moving on, so if VTD is better, then is VRD better? So we know that lenalidomide is a better immunomodulatory drug or IMiD. There is no randomized head-to-head study of VRD versus VTD, but there are many historical comparisons, and based on that, VRD has been called as a de facto standard of care. It leads to 10 to 15% improvement in the VGPR over the VTD in the historical setting, and as said earlier, it has different toxicity profile. So myelosuppression. It also hampers the stem cell mobilization. So when you are using VRD, you should collect your stem cells early rather than deferring them. And myelosuppression is important side effect because of lenalidomide, which should be kept in mind. Moving on to next generation PI based regimen, so carfilzomib based. So it looks quite tempting to use this, and this is studied in the Forte trial, where KRD based induction was used, and it was compared with the KCD induction. So not really standard, but you could say that it's still very active regimen. And what this study, 3-arm study, looked at, first is the response rate at the end of the induction before transplant. And as is shown here, there is a huge gap between the VGPR or better rate when you use the carfilzomib lenalidomide based induction. So definitely, carfilzomib with cyclophosphamide cannot be used, and it is inferior to KRD based induction. And another goal of this study was whether we need to do transplant when you use a KRD like regimen. So that was a second part of this study, which we'll see later on. So these are the PFS curves for this. So the first arm was KRD 12. So good regimen, but no transplant was used here. Next was KRD and then transplant, and another was KCD and transplant. So KCD regimen did worse in terms of PFS. KRD regimen did KRD with ASCT did the best, and KRD without transplant was showing a drop, especially after the first few years. So even a potent PI based regimen we need to do transplant for this patient for optimal long term outcome. Then we move on to quadruplet based regimen. So typically a monoclonal antibody based regimen is used, and Cassiopeia has the longest follow-up as of now. So this study used a VTD, which is a probably standard, which was standard of care in the Europe as their induction regimen, and then patient were transplanted. After that, they use consolidation VTD, and then maintenance, which is not standard there, was not used. In the comparator arm, daratumab was added throughout, so induction, consolidation, and there was a dara maintenance. So this observation alone is something which is not standard outside was not standard outside the Europe even at that time. And what you see is there is an improvement in the progression-free survival by addition of daratumab, and also some data to show that there is overall survival improvement, though we need to allow this data to mature. But even at early median follow-up of roughly 40-45 months, you don't expect more than 40% of the event to happen by 45 months. But you are seeing an overall survival difference. So definitely with the VTD as a comparator, addition of daratumab leads to progression-free survival and probably overall survival as well. So Cassiopeia, another point which again was driven is MRD negativity. So you achieve more MRD negativity if you use daratumab, and this has independent predictive value of progression-free survival in this trial as well. The next study is VRD and addition of DARA. So this is a phase 2 study from US where RVD was compared. This is what we want to see, and where comparator arm receives lenalidomide maintenance is a fairly standard treatment in this patient population. And this study doesn't have a long follow-up. This is a phase 2 study, and PFS and overall survival are not really showing much of difference, but we need to see more follow-up as both the arms are doing very good. But early readout on MRD suggests that if you use DARA, the sustained MRD negativity at 12 months and 6 months apart is good. So probably this will show some difference in the long term. And the phase 3 Perseus study, DARA VRD, is ongoing, which will give us the final or definitive result on this. So coming to conclusion about inductions, active induction is important, and VRD is the best triplet available to us. Quadruplet seems promising, and they have shown survival advantages some. And MRD negativity should be your goal. It can be used as a marker of active regimen in your patient. We'll move on to consolidation. So transplant is important consolidation strategy for eligible patient, and there are some studies which are done to see whether transplant can be avoided given the active induction regimen we have. Some study looked at early versus delayed transplant, whether we can defer the transplant, and some studies were also looked whether we need to do double transplant, which was the historical standard of care. So we'll see first EMN02 study. So this randomized patient after VCD, not a standard induction to VMT. That means giving melphalan, not doing transplant, versus a single or double autologous transplant as per the institutional practice. And after that, consolidation again in the randomized setting and lenalidomide maintenance. So this study answers the question whether you require transplant or not when you are using a bortezomib based regimen, and but not VRD is used here, and it also has used VRD as a consolidation and maintenance, which is standard. So what this study shows is there is no difference in overall survival in the early follow-up period, and progression-free survival is okay. This means that if you defer transplant and if you are able to treat them well after that. There is no difference at the early time point or immediate time point. But when you see the extended follow-up, the overall survival difference start emerging. And this typically happens in a transplantation trial. You need to look at their long-term follow-up, as these people you have even a second PFS, which is better as compared to non-transplanted arm. So this trial sort of answered that question, that if you are using a VCD based induction, probably deferring transplant is not a good idea. The IFM study was doing a RVD induction, and this was followed by RVD consolidation or transplant in the other arm. And these people are allowed to undergo transplant if they are not undergone in the first. So this basically answered the question whether you could defer the transplant in the light of a RVD like potent induction regimen, and all these patients received maintenance. So what this study shows is there is no difference in overall survival, and there is a gain in the progression-free survival, which is roughly 12 to 13 months for this study. But this doesn't say that you don't have to do transplant. So for doing a transplant at the time of salvage, you have to collect the cells, store the cells, and it is difficult to do transplant at the time of relapse. Even this study, I think 20 to 25% of the patient didn't undergo transplant in the RVD alone arm. So we should be keeping this in mind, and we should be deciding for our individual patient whether it is feasible to do stem cells. The next question is whether we need to do consolidation with tandem autologous stem cell transplant. So this was answered as a part of EMN02 study, where double transplant were done for some of the patients. And what it shows is there is a progression-free survival advantage in this patient, and overall survival advantage is also there. But you have to realize that this is EMN02, the induction regimen was VCD, and that is a criticism, and that is the reason why this has not caught up. But what this study again showed, that the results were really good, or required double transplant in patient with high risk cytogenetics. So basically 17p deletion. So this could still be a good good treatment modality for high risk patient. If you look at the stamina trial, which answered two questions, whether we need to do second transplant as a consolidation, or whether we can do away by giving a VRD as a consolidation as opposed to maintenance. So maintenance is standard, and these are two experimental arm for this matter. And what this study shows is there is no difference in the event-free survival and overall survival either of these approach. So when you are using VRD based induction, that may be the reason we are using a good treatment. So it doesn't matter whether you are doing one or two transplants. So this is a differing result as compared to the EMN02 study. But this study also looked at the number of patients who underwent transplant. So that's a treatment received per protocol analysis rather than intention to treat analysis, and it showed that the high-risk patient probably benefit by doing the tandem autologous stem cell transplant. So there is probably open debate about doing tandem transplant for high-risk patient. I think it's important when we don't have much of option down the line for our high-risk patient. So to conclude, transplant remains standard of care even in the current novel agent era, and it should not be deferred, or we should be very careful in deferring in our setup where the salvage transplant are not very feasible. Tandem transplant probably high risk subset we could still think of, and if someone has received a suboptimal induction. We'll move on to maintenance treatment quickly, and maintenance, there are a lot of studies, and I pull out this from a meta-analysis where you could see there is a significant overall survival difference. So this is something which is very important to note. And even the largest study showed a prolongation of, or nearly doubling of PFS with the use of lenalidomide maintenance. So it was, I think, 25 months to roughly 54 months like of PFS if you use lenalidomide maintenance in a transplant eligible patient. The benefit was less in non-transplanted patient, but still there is a benefit of that. One issue with lenalidomide maintenance is activity was not very good in high-risk cytogenetics. In fact, they show it is detrimental to do this. But this has not been really understood. Because of this, people tried bortezomib-based maintenance, and there is data from HOVAN that in high-risk cytogenetic, especially in deletion 17b, if you use bortezomib throughout the treatment for induction, then do their transplant, and then you use in the maintenance, their outcome tend to be equal. Very small number of patients, but definitely something to consider. So based on this, high-risk patient, especially 17p deleted, are considered for either bortezomib-based maintenance or bortezomib and lenalidomide-based maintenance, but data is really not strong. Talking about high-risk patient and their benefit from lenalidomide maintenance, so we have recent readout from myeloma 11 study. where even high risk patient and ultra high risk patient benefited on lenalidomide maintenance. So probably you should use lenalidomide, and if you want additional bortezomib based maintenance in this patient as well. DARA maintenance. So recently we have read out on Cassiopeia study where DARA was given as a maintenance, but the comparator was observation, which is not really standard of care, and which showed a PFS benefit. And we should know that the benefit was not really good in patient who received DARA as a part of induction. So definitely we need more data for DARA maintenance in this setting. So to conclude, lenalidomide maintenance remains standard of care for this patient population. For high-risk patient, probably we may have to do more than just lenalidomide-based induction, and adding bortezomib or using bortezomib may be a good strategy. For daratumab, we have to see more data probably. And the duration, so there are ongoing studies how long we need to do it, and MRD guided studies might answer that question. So we move on to non-eligible or non-transplant eligible multiple myeloma patient. So this is one subset where the improvement is not as good as what we saw in the transplant eligible patient. The traditional regimens were melphalan based, so melphalan prednisolone. The first addition of thalidomide lead to a significant improvement up to a year in the overall survival. Then when we use newer novel agent, for example, bortezomib or lenalidomide, it probably led to further improvement in the overall survival. And for the first time in this patient, you could see a 5-year as a median overall survival. And now we have these 3 recent regimens, so VRD and the daratumab based regimen. We will see them in detail in the next few slides. So this is a SOC study which defined the role of RVD. Actually, this was not a non-transplant eligible study. So these were patients who were not intended for transplant. So the median age of this study population was 63, probably more relevant to our patient where they don't undergo transplant. And they were randomized to RVD versus RD, so doublet versus triplet. So the context here is elderly people, whether they are able to benefit by addition of drug where toxicity is a concern. So relatively younger population in this study, and this study very nicely show that there is not only a PFS difference but also overall survival difference in this patient population. And as age advances, the benefit goes down. So we should be careful in using triplet for elderly patient, but definitely if feasible and if someone can tolerate, this leads to improvement in the PFS and overall survival as well. And this is probably the recommended regimen for a standard or fit patient who is not transplant eligible patient. Then we have 2 studies which looked at daratumab addition to this drug, and first is VMP, which was kind of mainly a European regimen where daratumab was added to there in a randomized fashion. So Dara VMP versus VMP, and the next was Maya trial. So lenalidomide dexamethasone with or without daratumab. So this is 2 randomized studies looked at utility of daratumab in non-transplant eligible patient population. So here the median age of this patient was more than 70. So these are truly non-transplant eligible studies, and I think these are the studies to look when you have a truly elderly patient. And both the studies showed a very good improvement in the progression-free survival. So you could see that it jumps from 19 months to 36 months, nearly doubling of PFS with addition of daratumab in the first line. And with lenalidomide and dexamethasone, the median is not reached in the DARA versus 34 months in the RDA. But probably these are the best outcome you could have in this elderly patient population. And not only this, this also leads to improvement in the overall survival. So we have 3 upfront daratumab studies showing overall survival difference, 1 in transplant eligible and 2 in transplant non-eligible patient, and probably we are going to see more mature data from these kind of studies. Lastly, we'll talk about some of the things which we have to do daily in our clinical practice. So one thing is, when you treat elderly patient, we have to be careful about the doses, and depending upon their age and comorbidities, you have to drop down the doses. So typical dose 0, dose level -1, and dose level -2. So probably age more than 65, dropping down a dose, and additional drop for intolerance or additional comorbidity should be kept in mind. And we have to be thoughtful about this. We can't just routinely use a regimen. VRD light is a very popular regimen, so that is something which we should keep in mind. Next is renal failure is quite common. Roughly 20-30% of the people will have, and drug like especially lenalidomide, melphalan, zoledronic acid will require dose modification. Cyclophosphamide also sometimes we forget, less than 10 ml. No, they say it should be given 50% dose. So we should keep this kind of finer things in mind when we want to treat our patient. Next is neuropathy, very important thing. This is, we keep on giving them, and we have to realize that we have to look at the early signs of neuropathy. So cramps, calf pain, or some uneasiness, etc., could be important things. And second thing is, whenever there is associated pain, the neuropathic grade is upgraded for this bortezomib based in neuropathy. And second thing is the dose reduction is quite steep. So any person with a grade 1 neuropathy with a pain, or a grade 2 neuropathy, should have a 1 milligram per meter square dose reduce. Anyone who has a grade 3 neuropathy or grade 2 with pain, you have to hold the treatment. So it is very kind of low threshold for decreasing the dose. And a person with a grade 4, so if someone has permanent loss of function or sensation, you have to discontinue the treatment. So this should be kept in mind, so that we don't end up having toxicity for our patient. So to conclude that, I think first line treatment is important, and it is rapidly changing. And this is important decision we have to make for our multiple myeloma patient. Prognostication is also improving, and the emerging role of MRD for prognostications, which we saw. VRD or DARA-based induction followed by transplant and maintenance seems to be the current standard and associated with best outcome in newly diagnosed transplant eligible patient. For non-transplant eligible patient, I think the value of monoclonal antibody is really good, and the antibody-based regimens are, if feasible, should be the treatment of choice. Maintenance treatment helps to improve the outcome, and we will see more data with newer drug, but lenalidomide and sometime proteasome inhibitor should be used. And I think paying attention to supportive care and appropriate dose modification for individual patient is important. So I will stop here, and if there are any questions, I will answer. So first question is by Lingraj, role of tandem ASCT in the era of novel therapy. What is the use of MRD off trial in the era of novel agent therapy? So as I discussed, Lingraj, probably the tandem transplant data has two setup where you could consider. One is someone who has received inappropriate treatment, or for that matter, you don't have a good salvage option. See, the people in the US are able to give fourth and fifth line, and they have salvage option. So that is one thing which we should keep in mind. And second thing is definitely high risk patient, so should be considered for that matter. So deletion 17p, excellent example. Plasma cell leukemia, where you could consider. Second thing is, what's the use of MRD off trial? So only use as of now is the prognostication. We are not able to. We don't have any data that if you change your treatment based on MRD, it improves the thing. But we have from that Dr. Munsi's meta-analysis, we have data for more than 10,000 patients, and it is showing overall survival difference in MRD positive versus negative. So if you have something which is shown to give higher MRD negativity rate, I would be inclined to use that as compared to a person or a regimen which gives less MRD negativity rate. So that is only used, but we don't treat patient based on MRD values as of now. Achilles duration of lenalidomide maintenance. So there is a divide between the lenalidomide maintenance, but I think the best result are seen with the continuous therapy, be it in transplant eligible or non-eligible patient. Probably not everyone needs this, and discontinuation based on the response or MRD may be there. But as you saw from the, for example, first trial, where continuous RD was the best treatment in non-transplant eligible patient. So probably a longer duration, especially if you are not using a very intensive treatment, is probably important. But minimal of 2 years should be considered. Again, Lingraj has same questions. Both transplant eligible and ineligible for lenalidomide maintenance duration. So same thing, Lingraj. Probably 2 years is the minimal duration. If someone is MRD negative, probably they will not benefit as of now. But the uh, European tendency is to stop it after that, and American tendency is to continue. And for non-transplant eligible, probably there is more data to continue it till progression. Uh, uh, Dr. B.K. Mishra has asked, is there any role of thalidomide still left in any type of patient? So sometimes we have to use thalidomide, and no, VTD was a very good regimen. In fact, VTD was probably underused as compared to VCD. It had a good outcome, but I think issues with the tolerance. Second situation where VTD means you will avoid lenalidomide and use thalidomide is person with renal failure, because this both bortezomib and thalidomide doesn't require renal modification, and in person with myelosuppression where lenalidomide is a problem. So probably VTD can be used, and obviously it is cheap, so that is one thing. Is the 2-year cutoff arbitrarily chosen? I'm not sure how this cutoff was chosen, but my feeling is whenever you want to choose this kind of strategy, they will look at the pattern of relapse. And what was happening is they saw a 25% cutoff within first 2 years, so that was considered as a cutoff for Harris. So probably that's the reason, but uh, this seems to be arbitrary. All right. Any other questions? If none, then we will stop here, and thank you everyone.